morning, everyone. Welcome back. I think it's quite important to remember a little bit of our history. The diagnosis of acute tubular necrosis was made to describe an entity when there was a bombing in London during World War II, and Biomarkers described cases of acute loss of kidney function in severely injury crash victims. Histological findings were patchy necrosis of renal tubules at autopsy. So the terms acute tubular necrosis has been used for years. Actually, the interesting thing was that the mortality for acute renal failure approached almost 100% in World War II when there was no treatment available. But then acute hemodialysis was first used during the Korean War in 1950 to treat military casualties, and this decreased acute renal failure mortality to about 50%. And this was due to the so-called hospitals on the field that actually were called MESH, and this was the first application of the rotating drum as hemodialysis treatment for patients wounded during treatment. The pictures are courtesy of Dr. Paul Teshan, who was one of the pioneers in this field. Now, the interesting thing was that fluid resuscitation on the battlefield with the rapid evacuation of casualties to hospitals by helicopter was optimized in the Vietnam War. It's interesting how much the war has affected the history of AKI. So injured patients were actually rapidly evacuated, and acute renal failure syndrome was diagnosed 1 in 200 in the Korean War, while 1 in 600 in the Vietnam War. So the idea that taking the patient to a hospital facility quite rapidly was probably the most important solution for the syndrome. Now, if we look a little later in our own population in Vicenza, we must say that from 74 to 79, we treated 48 cases, and only 15% of these cases were treated in the ICU, and all the rest were medical causes for acute renal failure. Mortality was approximately 54%. Now, the same population, same hospital from 95 to 2000 was about 525 patients treated. I remind you, this was also the period in which we studied the effect of dose on renal replacement therapy. Anyway, only 8% on the world, all the rest in the ICU, and mortality was more or less the same. So putting together nephrology and intensive care had the significance of trying to better understand the general pathophysiology of AKI. One of the questions that we are often facing is the problem of diagnosing AKI and reporting AKI. And here you see, both in ICU patient and hospital patient in general, how much the so-called AKI incidence can be different, although it is evident that ICU is playing an important role as a producer of AKI cases. There is no question that community-based AKI is increasing. It's increasing both if you require or don't require dialysis, and this is increasing costs and consequences from the clinical point of view and from the social point of view, including, of course, length of stay in the hospital and so on. One of the reasons for the increasing incidence is absolutely the presence of comorbidities, the presence of iatrogenic interventions, and the aging of our population. But then we have multipliers like sepsis, and specifically speaking about septic shock and severe sepsis, although this is the old classification, you can actually see how much AKI percent increase progressively when this syndrome is present. We have been interested in looking in the effect of severity of AKI, and it is now clear that if you move from non-AKI to stage 1, 2, and 3, or you require dialysis, actually this severity correlates with the specific level of mortality. And not only mortality is involved, but also ICU length of stay and the hospital length of stay, in particular for patients that require renal replacement therapy. So reporting epidemiology of AKI is a difficult task, and you see numbers that are very, very different from different publications, depending basically on the population studied and the definition used. So we don't even know if the growth of acute kidney injury is a rising tide or is just a closer attention to detail from diagnostic point of view. But however, you can immediately see that if you use a doubling of serum creatinine as a criterion for diagnosis, your incidence may be very low. While if you use the most recent delta 0.3 milligram per deciliter, your incidence of AKI can be really, really, really high. Now, we have been very creative in terms of definitions of AKI. We found more than 35 definitions in the literature, and it is almost impossible to compare papers using different definitions. In particular, I must say that in radiology and in cardiology, using this term worsening renal function makes completely difficult to compare different papers. So, there was a need for a consensus definition, and you see this lady says Mr. John Doe in the world has acute renal failure. So she thinks he has a delta 25% in creatinine, while the other guy thinks that the patient requires renal replacement therapy. And if we do not harmonize the language, definitely this confusion is present. John Kellum has clearly also pointed out that severity has to be placed in the equation. Otherwise, you cannot say this is a dangerous syndrome or is a deadly syndrome, and so on. So the AKI group analyzed this problem and clearly made the point that consensus was needed for reason of quality assurance, for epidemiology, for clinical trials. And this came out from one of the early AKI sessions in 2002 here in Vicenza, when we developed the first metrics for characterizing AKI using creatinine GFR criteria and urine output criteria in the so-called rifle system. Now, this rifle has been validated in an enormous amount of patients, and it is now clear that severity of category in the rifle correlates with mortality, hospital and ICU length of stay, costs, and most recently, renal recovery. Some changes have been brought by the AKI group, especially on the window for 48 hours for the change in creatinine and the value, the absolute value of 0.3 milligram per deciliter to be considered important to make at least the diagnosis of stage 1. This has brought some problems and complications because how do we diagnose the baseline creatinine? We have used back calculation, we have used MDRD equations, admission serum creatinine, nadir creatinine, pre-admission serum creatinine, plus we know that malnourishment, muscle wasting, or fluid overload may affect creatinine dosage. So this is highly speculative, as my friend Rinaldo would say. Now, a better approach has been made when AKI brought the concept that AKI is a continuum that starts from a condition of nearly normal kidney with increased susceptibility and possible damage, and then dysfunction and finally failure. And the biomarkers that identify these characteristics may be helpful in specific moments of this continuum. Biomarkers can be generated at different levels in the nephron, linked to specific damage to specific areas of the system. It has been clarified that the damage to the kidney starts very early with the movement of integrins, adhesion molecules, depolarization of cells, and only in this moment some molecules are expressed to characterize the damage to the cells, but definitely much earlier compared to what has been done so far, just measuring a decrease in GFR and the later increase in serum creatinine. So we may say that actually we may analyze biomarker of structural injury and biomarkers of functional injury or biomarkers of dysfunction. Some reports have analyzed the performance of these molecules both in serum and urine, and have analyzed different molecules that have been described as good predictors or capable to define established AKI, early AKI, and severity of AKI. One of these molecules is NGAL, which seems to be quite significant, especially in pediatric population undergoing cardiopulmonary bypass. And this molecule has been also interesting for another reason, because it seems that in the very early phase, it chelates iron and tend to limit the level of damage in the tissue, while in the late phase, it transports iron for proliferation in the site of the lesion, possibly describing some protective effect. And some specific studies using NGAL luciferase reported have been clarified that this molecule is clearly expressed at the kidney level. Another molecule has been urine KIM1 that seems to be pretty specific for ischemic acute tubular necrosis, although there are some noise for other conditions. One of the important things about KIM1 is also that it co-localizes with markers for dedifferentiation proliferation, so that, again, these molecules probably are not just innocent bystanders, but they participate in the pathophysiology of the lesion and in the pathophysiology of the recovery process. Now, today we have an enormous amount of molecules under analysis with a lot of literature, with the possibility probably in the future to create a real mapping of the different phases, initiation, extension, maintenance, and repair of the AKI syndrome. Recently, the group at Mayo and the collaborative group from California and John in Pittsburgh have made a paper on discovery and validation of cell cycle arrest biomarkers, which represent, again, molecules expressed by the cell when damage avoids replication to avoid to perpetuate the damage in subsequent cells. And this product of these two molecules, TIM2 and IGF-BP7, seems to overperform any type of other biomarker used so far. Now, this interesting study that was published by Michael Hayes some time ago shows clearly that those patients who have a positive biomarker, although creatinine is negative, they have the same level of complication in terms of dialysis, mortality, or combined outcome of patients that have positive biomarker and positive creatinine, and definitely worse than patients who present negative biomarkers. This allowed the AKI group to develop a conceptual model in which In case of functional change alone, you have functional AKI. In case of insult and damage alone, you have subclinical AKI. And in case of both, you have an established AKI. And of course, there may be a passage from one to another class. So we published in Kidney International in 2013 the results of the AKI conference made in Dublin, where actually the idea of new diagnostic criteria included functional criteria and damage criteria, possibly including biomarkers. Now, the problem was how to grade the severity, and we have tried several approaches. One is this NGAL score in cardiac surgery associated AKI that we published a few years later, somehow correlating the level of severity with the level of biomarkers. The same in terms of risk for AKI and development of AKI has been done with the use of cell cycle arrest biomarker with discrete threshold values that may clearly describe moderate or very high risk to develop AKI. Now, the problem at this point is that we have a creatinine domain area where we describe very clearly stage 1, 2, and 3. We have an area that originally has been described by Stu and Mink as renal angina that is a condition of risk or when creatinine moves but doesn't reach the 0.3 milligram per deciliter. And we have now a region where biomarkers move even in the absence of creatinine rise. So I think that we may say that AKI is a severe condition in which kidney damage and dysfunction may either coexist or they may actually be two separate entities, and biomarkers can help to differentiate that. But we need absolutely not to neglect any possible signal from the kidney because, as we published some time ago, subclinical AKI is still AKI. And this is how today we can see the definition classification for AKI that moved from the bombing of London and the diagnosis made based on total anuria to the 35 definitions to rifle that finally included some biochemical metrics, to the Acute KDIGO classification, and finally today we moved into the molecular diagnosis where we can somehow define the AKI risk of susceptibility, what has been called by Nevin Katz acute kidney stress or subclinical AKI, and finally trying to use this information to affect the outcome of the patient. Now, we published this little divertissement on Lancet a few years ago, when we compare what happened to the heart. If you have a patient arriving at the emergency room with chest pain, you immediately do an AKG, and if you have ST elevation, you make the diagnosis of ST elevation myocardial infarction. But if you don't, you definitely use troponin as a discriminator, and you make the diagnosis of non-ST elevation myocardial infarction. Basically, today we may have an AKI which has a creatinine increase or even a non-creatinine increase AKI. The other point is that biomarker can help us to identify patients who have either complete recovery or partial recovery. And when partial recovery occurs, this kidney, for the following months and years, may actually be subject to high susceptibility to evolve into the slippery slope of chronic kidney disease. And I think that later on the speaker will present how this evolution is possible. So the natural history, once the diagnosis is made, is toward full recovery or evolution into partial recovery or to CKD or either directly to end-stage kidney disease. We clearly know today that AKI is a doorway for CKD, and a high risk to develop need for renal replacement therapy is there. There is practically the possibility that several different kidney attacks may affect the evolution. At this point, it may be just subclinical. Normal baseline GFR may remain stable, but you may actually have subsequent attacks that may become clinical. So if we have to use a cartoon and we use the blue line to describe susceptibility of the kidney based on progressive loss of renal mass, we may say that even in presence of high exposure intensity, when susceptibility is low, you may not develop a clinical syndrome, but when you have a high susceptibility, even a small exposure intensity, a drug or a contrast medium can be done, can represent a real problem. Now, we have done a very interesting prospective study in which we basically analyze biomarkers and renal functional reserve before cardiac surgery, and after discharge, we measured again at 3 months renal functional reserve. What I want to show you is that basically the distribution of renal functional reserve in patients who underwent this therapy shows clearly that if you have a reduced renal functional reserve, you have higher chance to develop AKI stage 1, 2, or 3, which describes very well the susceptibility in the kidney. Let me move fast because I see I am a little late. What is interesting is in the follow-up of these patients, we found that patients who either had acute kidney injury by stage 1 or 2, but also patients that had AKI just by increasing biomarker, have a significant reduction in renal functional reserve at 3 months, showing that there is a damage in the kidney, although clinically not evident, because the so-called recovery that may actually go to a GFR greater than 90 may be full if your renal reserve is intact, but it may be apparently full if you have a baseline GFR which is normal, but your renal functional reserve is reduced over time. So, in conclusion, I think that we may say that this is a complex syndrome. Pre-existing or concomitant conditions represent important risk factors. The intensity of the insult and the susceptibility of the kidney play a pivotal role in developing the syndrome and its characteristics. The level of insult and severity of illness will influence the balance between capacity and demand for blood purification, and the definition of AKI must include today biomarker criteria, as suggested by AKI 13. Renal functional reserve, however, is a further important component in the evaluation of risk and level of recovery. In other words, those patients who had an acute kidney stress show that they have a reduced renal functional reserve. These are patients that have already begun their history of chronic kidney disease. Those patients after AKI who develop reduction in renal functional reserve have had an insult that has partially destroyed some of the renal mass. Thank you very much.